Hello everyone. Today I will be discussing febrile seizures, one of the most common neurological events encountered in pediatric practice. This presentation is brought to you by the Docsaab's Diary. Let's begin with an introduction to febrile seizures. Febrile seizures are convulsions that occur in children between 6 months and 5 years of age, triggered by fever, specifically body temperature exceeding 38 degrees Celsius or 100.4 degree Fahrenheit. It is crucial to note that these occur in the absence of any underlying neurological disorders, central nervous system infections, or metabolic disturbances. These seizures represent the most common type of seizures in otherwise healthy children, affecting approximately 2 to 5% of the pediatric population globally. The peak incidence occur between 12 and 18 months of age. While these events are typically benign and self-resolving, lasting only seconds to minutes, and do not cause permanent brain damage or intellectual impairment in most cases, they can be extremely alarming for patients and caregivers due to their dramatic appearance. It is important to emphasize that febrile seizures are not epilepsy. They are provoked only by fever and rarely recur beyond childhood. Of particular relevance to our practice context in India, particularly in regions like Delhi, febrile seizures are more prevalent with incidence rate ranging from 10 to 17%. This notably higher than 2 to 7% observed in Western countries. Febrile seizures are classified into two main categories, simple and complex. Simple febrile seizures are more common, accounting for approximately 80% of cases. These seizures are generalized, affecting the entire body and last less than 15 minutes. They occur only once within a 24-hour period and do not involve focal or localized symptoms. The child has no prior neurological abnormality and is developmentally normal with no evidence of CNS infection or other acute neurological conditions. Recovery is typically quick, with the child returning to normal within an hour. Complex febrile seizures are less common, representing about 20% of cases. These seizures last longer than 15 minutes, may recur multiple times within 24-hour periods, and can affect only one side of the body, what we call focal seizures. Importantly, complex febrile seizures indicate a higher risk of future epilepsy, approximately 2 to 5% compared to 1% in simple cases. The child is neurologically normal before the illness. A rare variant worth noting is febrile status epilepticus, seizures lasting over 30 minutes, which is associated with more severe outcomes, including potential brain injury. Understanding the etiology of febrile seizures involves examining both the risk factors and common triggers. Risk factors include age. The highest risk occurs between 6 months and 3 years. Children younger than 18 months have a recurrence risk of 35 to 50%. Genetics. A family history of febrile seizures is significant, with concordance rates of 35 to 69% in identical twins. Specific gene variants on chromosome 1q31 and 3p24 and others have been identified. Developmental factors. These include delayed developmental milestones, NICU stays exceeding 28 days, or pre-existing neurological issues. Environmental and nutritional factors, low birth weight, difficult labor, maternal smoking, or stress and deficiencies in iron, zinc, vitamin B12, or folate have all been implicated. Indian studies have specifically linked low hemoglobin, low MCV and MCH values, reduced serum sodium and calcium, low blood sugar, and antenatal complications like hemorrhage to higher risk. Common triggers include viral infections are the most frequent trigger, accounting for approximately 81% of cases. These include upper respiratory infections, gastroenteritis, otitis media, and specific viruses like human herpes virus 6, which causes roseola, influenza A, RSV, and adenovirus. Bacterial infections are less frequent, accounting for about 21% of cases, such as urinary tract infections or streptococcal pharyngitis. Post-vaccination, rarely vaccines such as MMR, varicella, or the DTP, IPV, H influenza B combination can induce mild fever and seizures in susceptible children, though this is unrelated to the vaccine itself. Let me describe the clinical presentation of febrile seizures. A febrile seizure is characterized by an abrupt loss of consciousness coinciding with fever, usually exceeding 38 degrees Celsius. Boys are slightly more affected with a male to female ratio of 1.6 to 1. There is no single fever threshold that causes seizures. Variability depends on individual susceptibility. During a seizure, children typically exhibit a generalized tonic-clonic activity, which includes motor activity such as rhythmic jerking or shaking of the limbs on both sides of the body, often accompanied by a muscle stiffening. Loss of consciousness, the child becomes unresponsive and their eyes may roll back or deviate to one side. Autonomic changes, physical signs may include vomiting, foaming at the mouth, or loss of bladder and bowel control, what we call incontinent. Respiratory effects, brief periods of cyanosis, a bluish skin tint may occur due to temporary changes in breathing patterns during the convulsion. Following the seizure, children enter what we call the post-ictal state. This phase is typically brief in simple seizures, lasting from few minutes to an hour. Common behaviors include extreme drowsiness, confusion, and irritability. While most children return to their baseline neurological state quickly, complex seizures may occasionally followed by a Todd's paralysis, a transient focal weakness in the limb that can last for several hours. Febrile seizures often occur within 24 hours of fever onset, sometimes even before visible symptoms appear. Unlike epileptic seizures, there is no aura or warning signs. In the Delhi and broader Indian context, upper respiratory infection dominate as precursors with the temperature averaging 38.9 to 39 degrees Celsius. Diagnosis relies on thorough clinical assessment while excluding mimics like epilepsy or CNS infection. History taking, clinician must determine the duration of seizure, the nature of the movements, whether generalized or focal, the peak temperature reached, and any recent history of illness or vaccination. Physical examination, a thorough examination is required to locate the source of infection, such as an ear infection, pneumonia, or urinary tract infection. We must also check for signs of meningitis, such as neck stiffness or a bulging fontanelle in infants. Lumbar puncture, this should be strongly considered if there are clinical signs of meningitis or if the child is under 12 months old and their immunization status for H. influenza or Streptococcus pneumonia is incomplete or unknown. Continuing with the diagnostic considerations, neuroimaging with CT or MRI, this is reserved for children with focal neurological deficit, signs of increased intracranial pressure, or abnormally large head circumference. Electroencephalography or EEG, this is not recommended for simple febrile seizure as it does not predict recurrence or future epilepsy. It may be used in complex or recurrent cases to evaluate for underlying genetic epilepsy syndromes. Laboratory studies, routine laboratory testing is not indicated for simple febrile seizures. Additional tests should be guided by the suspected source of infection. For example, children with vomiting or diarrhea may require serum electrolyte measurement. When evaluating a child with febrile seizure, we must consider several differential diagnoses. CNS infection such as meningitis or encephalitis, metabolic disturbances including hypoglycemia or electrolyte imbalances, rigors, these are shaking chills associated with high fever that do not involve loss of consciousness, genetic epilepsies, conditions like Dravet syndrome or GEFC plus generalized epilepsy with febrile seizure plus may first present as febrile seizures in infancy. Now let's discuss the management of febrile seizures beginning with first aid. Most febrile seizures last less than 5 minutes and resolve before medical help arrives. During an active seizure, the primary goal is to prevent secondary injury and maintain a clear airway. Positioning, place the child on their side in the recovery position on a soft surface. This prevents the tongue from obstructing the airway and allows saliva or vomit to drain safely. Safety measures, remove nearby hard or sharp objects, loosen tight clothing, especially around the neck. Observation, time the seizure from start to finish, observe the type of movement, whether it's jerking of all limbs or just one side, to report accurately to medical staff. Prohibited actions, do not restrain the child as this can cause bone or muscle injury. Do not place anything in the child's mouth as this poses a choking hazard and can damage teeth. Caregivers should seek immediate emergency medical attention if the seizure lasts longer than 5 minutes, the child has difficulty breathing or turns blue, the child is injured during the seizure, a second seizure occurs immediately after the first, the child does not wake up or remains unusually drowsy for more than an hour post seizure. Clinical stabilization. Upon arrival at a medical facility, the healthcare team prioritizes the ABCs, airway breathing and circulation. These include monitoring oxygen saturation, providing supplemental oxygen if needed, and establishing intravenous access if the seizure is ongoing. A rapid bedside glucose check is often performed to rule out hypoglycemia as a contributing factor. When a seizure exceeds 5 minutes, it is classified as prolonged seizure or status epilepticus and requires medication to stop the electrical activity in the brain. Benzodiazepines are the first line treatment due to their rapid onset. First line medication include lorazepam given intravenously at 0.1 milligrams per kilogram with a maximum dosage of 4 milligrams. This is the preferred hospital based treatment because it has a longer duration of action in the brain compared to diazepam. Diazepam given rectally as a gel at 0.5 milligrams per kilogram with a maximum of 20 milligrams per dose. Midazolam can be given intranasally at 0.2 milligrams per kilogram or buccally inside the cheek at 0.3 milligrams per kilogram with a maximum of 10 milligrams per dose. Midazolam is increasingly preferred for pre-hospital care because intranasal or buccal administration is faster and easier than establishing a rectal or IV route. If the seizure continues after two doses of benzodiazepines, second-line anti-epileptic drugs are administration via IV infusion. Fosphenytoin 20 mg phenytoin equivalents per kilogram, levetiracetam 40 to 60 mg per kilogram, valproate 20 to 40 mg per kilogram, phenobarbital 20 mg per kilogram. This is often used in younger infants. Fever management. It is common misconception that aggressive fever reduction prevents febrile seizures. Clinical studies have clearly shown that antipyretics, fever reducing medications do not prevent the occurrence or recurrence of febrile seizures. Their primary purpose is to improve the child's comfort and reduce metabolic demand. Recommended dosages acetaminophen or paracetamol 10 to 15 milligrams per kilogram every 4 to 6 hours. Do not exceed 5 doses in 24 hours. Ibuprofen 5 to 10 milligrams per kilogram every 6 to 8 hours. Note that ibuprofen is generally only recommended for children older than 6 months. Caregivers should focus on hydration and light clothing rather than ice baths or alcohol rubs, which can cause shivering and paradoxically increase body core temperatures. Prophylaxis considerations. Daily anti-epileptic drugs. Routine daily use of medications like phenobarbital or valproate is not recommended. The potential side effects including hyperactivity, cognitive impairment or liver toxicity far outweigh the benefits of preventing a benign seizure. Intermittent prophylaxis. In rare cases where a child has extremely frequent or prolonged seizures that cause severe family disruption, a physician must prescribe oral diazepam at 0.3 to 3 milligrams per kilogram every 8 hours to be given only during the first 24 to 48 hours of a fever. However, this is not routine practice due to side effects like lethargy and ataxia. Parental education and counseling. The most critical component of long term management is reassuring parents. Providers must emphasize that simple febrile seizures do not cause brain damage, do not decrease IQ, and do not lead to learning disabilities. Let's discuss the complications and prognosis. Short term complications, injury from falls or choking is rare. Prolonged seizures carry a risk of aspiration or hypoxia. Long term prognosis, the prognosis for simple febrile seizures is excellent. There are no cognitive deficits, normal IQ is maintained, and academic performance is similar to children who have never had a febrile seizure. Recurrence risk, 30 to 50% of children will experience a recurrence with higher risk in those with young age at first seizure, positive family history, or low fever at onset. Epilepsy risk, the risk of developing epilepsy is 2 to 5% compared to 1% in the general population, rising to 10 to 20% if seizures are complex or prolonged. Mortality, mortality is negligible, less than 0.1%. Rare complications, febrile status epilepticus has been linked to hippocampal scarring in animal models, and macroglia targeted therapies are currently under research. Overall, 95% of children recover fully with no increased risk of death. Regarding prevention, vaccination, vaccinate according to the recommended schedule including MMR, varicella and pneumococcal vaccines to prevent fever-inducing disease. These can reduce the risk of febrile seizures by 20 to 30%. prompt fever management, focus on hydration and light clothing, avoid overbundling the child, high risk avoidance, screen for anemia and nutritional deficiencies in vulnerable groups such as in Indian children with documented low iron stores. It is important to note that there is no proven prevention strategy specifically for recurrences beyond symptomatic relief and treating the underlying fever causing illness. Thank you for your attention, guys. And for more educational content on pediatric and medical topics, please like, share, and subscribe to the Docsaab's Diary. I welcome any question you may have.